Yes, so thank you everyone
Yes.
for coming today. I can't see all of you, but that's fine. We probably have, we managed to talk more after the presentation. So today I'm presenting the work I've been doing at the University of Manchester for the last 12 months. As Ari was saying, I recently joined the University of Cambridge. So I see some of my colleagues as well from Cambridge and from Manchester as well. This project is about increasing awareness about end-of-life care, and we focused specifically on hospice settings in the East Cheshire region. So I wanted to thank some of my collaborators. So Sandra Jones and Debbie Alexander from East Cheshire Hospice, and from University of Manchester, Chris Todd, Alistair Burns, and Michelle Briggs, and from UCL, and also Yang, and she's a postgraduate PhD student at the University of Manchester, and from UCL, Claudio Di Lorito, and PPI members that were excellent in providing support throughout the project, Marianne and Anne. So the idea of the project came from my previous experience in dementia research. I engaged with participants, with people with dementia and their carers in a previous project on mental health crisis. And I interviewed them about what was their experience of managing mental health crisis. And what was quite shocking is that even though there were mental health crisis services, these are secondary care services for mental health crisis across their region and well established, when I talked to participants, they didn't seem to be aware of any of these services that were there for people, specifically for people with dementia. So there was a mismatch between what was offered to them and what actually people were aware of about the existence of these services. So we wanted to see whether in end-of-life care this also was the case, and how we can actually improve their knowledge and understanding of what can be out there for end-of-life care for people with dementia. We know that people with dementia may have difficulties in accessing this type of services, and we will see later on during these slides why this is the reason. So we know that more than 50 million people have dementia worldwide, and estimates indicate that anything between 5 to 8% of older people aged over 60 may have dementia. So this is a major cause of disability, and so you can imagine, as if you've read through the literature, that there is increased dependency for this age group and for people with dementia in carers. So there is an increasing need for care, and also there is an increasing awareness that dementia is a progressive condition that requires appropriate care for end of life. But then we will see through the study findings, this is not always the case. So sometimes it's difficult to understand dementia in terms of progressive condition. So in fact, this results in poorer access to palliative care than, for example, people from other, having other conditions such as cancer. And they also are more likely to experience reduced quality of care and poorer outcomes in terms of pain management and symptoms control. So there are ways that the quality of care can increase, and through the evidence, this is through by considering tenets of person-centered care. So, for example, to ask the patient and their family carer what are their needs, preferences, and values for the type of care they need at that time. But this may be quite daunting to do with people with dementia compared to people living with experiencing other conditions. And so the people with dementia may advance stages when they need to access end-of-life and palliative care. And this is coming through discussion with clinicians working in hospice and through the evidence as well. It seems that it's quite difficult unless there is an advanced care planning in place, and we will see later on during the presentation, it may be more difficult for them to share their views, their preferences, as verbal communication may be impacted by dementia itself. And so we will see that providing person-centered care support in end-of-life care for people with dementia may be quite difficult, as there are also symptoms that may coexist at the same time, and the frequent occurrence of delirium in this patient group may affect the assessment and management that may not necessarily be tailored as much as one would. So through the evidence, we found that barriers impacting on the quality of care for people with dementia were described in terms of awareness, reduced awareness about dementia being a progressive and terminal nature, as much as cancer could be. And also the fact that during end-of-life care, dementia is very likely to be advanced at an advanced stage, and so there is an increased responsibility of care for the carer, who needs to balance who needs basically to manage the very difficult care situations, especially if there is no specialty care supporting them. And also the staff turnover can impact on the quality of care. Of course, this is actually linked to the recent project I'm doing in Cambridge with community district nurses. They report that there is staff shortage in community. So you can imagine that having very few community district nurses providing care at home of the patients means that they can dedicate very little time to each case. And as much as their clinical input is excellent, they still can dedicate not as much time as they wish they could. And so this indirectly affects the quality of care that the patient receives. So we wanted to explore what is out there and what is being delivered, and what are the elements of best practice for end-of-life care. We focused on East Cheshire because of the previous network we had with the University of Manchester, and this the main reason was because of the very good job they're doing for people with dementia. It may be we may think that people with dementia accessing hospice across the UK receive the same quality of care throughout the nation, but this is not necessarily the case, because even hospices that provide excellent support for people with other conditions may not necessarily provide dementia-specific end-of-life care. So a different care pathway, or maybe the care pathway used for people with other conditions may be adjusted to people with dementia, but with not necessarily previous training in place. So we focused on East Cheshire because of the excellent work they seem to be doing on dementia care. And this was a qualitative study lasting 12 months. And we had Anne and Marianne, I was saying before during the beginning of the presentation, they acted as co-researchers. They have done an excellent job supporting me with study material. So they developed with me the questionnaires and also the drafting the protocol for the project itself. But also we will be talking about this later, the proposal for the protocol for the systematic review as well. And they helped me with the data analysis. We registered this project on Open Science Framework, and I would really suggest doing something similar, because this is a way to publicly share your protocol with pretty much anyone that may be interested in your study. It's a nice way to share more than just a brief paragraph about what your project is about. Okay, so I was saying something about the systematic review. Sorry, they may look a bit populated, these slides, but I wanted to share with you, well, this is the list of co-authors for the systematic review. And we registered the systematic review and meta-ethnography on Prospero on the 25th of July 2022. And we completed the full manuscript of the review and submitted to the journal Aging and Mental Health on the 26th of March. So a couple of last week, 2 weeks ago. And we wanted to explore the experience of people with dementia and their family carers of hospice care, of end-of-life and palliative care. And we wanted to do this before engaging with qualitative interviews. We wanted to explore this through the evidence to see what is the review, what other authors have done in the past or more recently. So, and are we replicating their findings, or are we finding something different in the UK setting? So we used Perspective to organize our search strategy, and we had to adapt the domains, the search domains, according to each of the databases that we used. Okay. So for data screening, okay. So this is briefly described as the as you can read this more on the protocol that has been registered on Prospero, but also hopefully we will publish the manuscript soon, so you will be able in a couple of months to read it more on these in much more detail. So we used 3-level screening. The first level entailed me and Yang and Claudio independently screening title and abstract of the articles against our inclusion and exclusion criteria. And then the second level included the full text screening for each of the studies that passed the first line, the first level of screening. The third level, me and Claudio, my colleague, screened studies against the Spencer et al. Framework for quality assessment in qualitative research. For data analysis, we used meta-ethnography, and we reported our results as per the eMERGE guidance. So we use meta-ethnography to explore third-order constructs. So the third-order construct is basically our interpretations of the author's findings. The authors of the studies that we included, their interpretation is the second-order interpretation. And their second-order interpretation is based on first-order interpretations, which means the participants' views as the authors report in their studies. So we included 4 studies, and 3 studies were from the US and 1 from New Zealand. None was from the UK. Which made our empirical study, qualitative interviews on hospice even more relevant, because none of the evidence was based on UK setting. So that was from one region in the UK was quite useful to share. So the 2 third-order constructs that we found through meta-ethnography were expectation of care and barriers to quality of care. We use psychological theory based on expectancy disconfirmation for user satisfaction, because by reading the findings, we found that there were care expectations based on the type of care, of end-of-life care that was provided in the hospice. And when their care expectations were not matched by the hospice care, there was reduced quality of care. Their experience of quality of care was reduced. And also there were buffering effects based on not feeling supported, or carer being constantly questioning the care and having fear of discharge from hospice for the person with dementia. So this is a summary of the themes that we found. So on the left side, there are the third-order construct, which in other terms may be seen as overarching themes. And then we have theme categories for each of the third order construct. So, okay. We can discuss more on this if you have questions. So feel free, as Emily was saying, to put them in the text, in the message, in the chat, and then we will then talk about them. So this was the expression of the express synthesis. So as part of the meta-ethnography, whatever you find, you will need then to express in a paragraph or two whatever you found. And so there would need to be a sort of line of argument. And what we found was that, as I was saying before, when carers' expectation of care were not matched by either hospice staff or the physical care environment, for example, the hospice was not dementia friendly, then the experience, there was reduced level of satisfaction in carers with respect to the care received. And on the opposite side, when the hospice, when there was the care expectation was matched by the staff, or because the hospice setting was enough, was adequately dementia friendly for the carers, there was a good report of satisfaction in carers. And what the evidence showed was that having good knowledge of palliative end-of-life care early on during disease trajectory, and also that dementia is a progressive condition, could help carers better handle the difficulty of end-of-life dementia care. So we will see later on during the as findings, as part of the findings of the qualitative study, that the that even carers that reported knowing that dementia was progressive, because sometimes they experienced discharged from hospice, they because they stayed longer than 1 or 2 months, they reported that there could be a sort of misunderstanding because of dementia being stabilized instead of being progressive. So there would be the need to be very clear during hospice access point, that what dementia care entails and why people with dementia may be discharged from hospice and in which cases. And that may be quite useful for carers to know. Okay, so this is the actual empirical study. This is this slide is about the qualitative interviews we have done. We first explored what was the experience of hospice for carers and people with dementia through the evidence, and now through empirical study, through qualitative interviews. So we used purposive sampling, and we recruited up to 20 participants, 10 carers and 10 staff working in the hospice. And we framed questions around their experience of accessing the service and quality of care that was delivered or received, depending on who we were interviewing. We have to go through full HRA REC approval because this was based on NHS setting. So we were interviewing them about the type of care, quality of care they received within the service. So we have to. This took quite a while. I would say 5 months. To get approval in place, and we had this on the 18th of October 2022. So carers were eligible if they were 50 years old and over. They were, well, they had the person with dementia had passed away, and at least a month before we approached them to recruit for the study, because we didn't want to interview them during a very sensitive time. We actually found out that was very emotional for them to talk about their experience of care anyway. even if the time passed. But we had a very good support from the clinicians at the hospice, so they could then get back to participants and make sure that they were okay after the interviews. So that was quite good coordination. So they had to be English speakers, and there was no restriction on sex. And for clinical personnel, they had to, well, of course, carers, sorry, they had to be willing to discuss about dementia and their experience of care. And for clinical personnel, they had to be registered and qualified healthcare professionals and 25 years old and over. We thought about the age as criterion, but this is mainly because we thought that anyone who is post-qualification would be around 25 years old or over. And they also had to be willing to discuss about their experience of delivering this type of care as key worker. And also they had to be English speaker and no restriction on sex. English speaker because I only speak English or Italian, but so it may be difficult then to for the resources we had at hand, well, to organize translation during the interviews, post-interviews. Okay, so we used thematic analysis, and so we analyzed all interview transcripts, and the coding was facilitated through the use of NVivo12. Again, my colleague and I identified initial codes, and then we defined teams and subteams in relation to the study objective. We drafted a codebook, and we used this codebook to make sure that we could code them in a similar way, but 3 versions of the codebook were necessary to refine our coding strategy. These are the results, and okay, so we found 3 main themes. So pre-access to service. This theme refers to the time hospice personnel and carers reporting on their experience of pre-access to hospice care. Their experience was reported in terms of having advanced care planning in place, and this was either a barrier in case advanced care planning was not in place at the time they were admitted to the hospice. And so it may have, then it was mainly the carer's responsibility to share what they thought would be their views of the person with dementia with the clinicians. And when the advanced care planning was in place, this could facilitate the care delivery. And the East Cheshire, we will see this later on, but the East Cheshire, part of the East Cheshire care pathway involves also discussion about advanced care planning for patients in the outpatients clinic. So they can access through the Sunflower Center, which is a sort of daycare center, this type of information. So there is information sharing, but sometimes people access hospice when, well, at very last minute, when actually the person has not done any advanced care planning before when they could. So this can make things more complex. And also barriers to access, and our hospital care was often the first option for people with dementia. So people with dementia were not all the time accessed hospice care for end-of-life care, and because of them being in advanced stages, on advanced stage, they were more likely to experience injuries related to their frailty, and so they were very likely to go to be admitted to emergency hospital well, care. And so they, if that was the case, they reported reduced experience, well, reduced quality of care in their experience. Because most of the time that was not the optimal type of care for the person. So then the second theme was roles and responsibility within hospice care. This team refers, this team is about the roles clinical personnel, but also carers assumed within the hospice environment. The clinical staff reported that other than their clinical input, as part of end-of-life care in dementia, they also found themselves acting as counselors and doing basic psychological support, providing basic psychological support to the patient, but also to the carers. So to the patient, they recounted sitting next to the person and trying to soothe their agitation by caressing their hands and staying there, just stay there with the patient. And they report him being excellent and well, with support of the carer that could explain how to understand when the person was agitated, but also I think through training and by working in the hospice, they could easily understand when the person was being a bit agitated, even if in the bed, laying down in the bed. And yeah, so there were strategies in place to help improve the care experience for the patient, but also the carers. Most carers reported a transitioning in their role, in their caring role, because having the person in inpatient hospice care meant for them to release part of their responsibility of being a carer 24-hour. But we will see then that there are also difficulties during the last period of end-of-life care. This is about the third theme we found. And this is about the discharge pathway that is in place for people with dementia during end-of-life hospice care. And sometimes people with dementia could be discharged from hospice because hospice is not a long stay place. So if the person with dementia risks to stay there for a very long time, I think usually it would be more than 1 or 2 months, depending on the hospice. But if it's a very long stay, then they probably are discharged. And but this doesn't mean that they are discharged and they stop having support from hospice. But you can imagine that there is fear in the carer of, they reported having fear of going backwards. So as if they were back to square one, being carer 24-hour again, as they were before access to hospice. But so good communication happening at the time point of accessing the hospice could actually be better for the carer. There was one carer reporting that that she was amazed by the fact that the person, their loved one with dementia, was not discharged already, because the person was staying there for a very long time. So because she knew already that discharge was an option. So so when this was disclosed, then the carer would be knowledgeable and have a quite good understanding of what discharge could mean for a person with dementia. Okay, so yeah, so these are tables. The following 3 slides contain the tables with the theme, the sub-theme, and the participants account. No patients. I only could interview bereaved carers and clinical staff, because the people with dementia and end-of-life care, first of all, we wanted to interview bereaved carers, so people that the person with dementia had passed away anyway, but also because the people with dementia at advanced are so in an advanced stage that would be very difficult to communicate with them anyway. So with advanced care planning, I think I explained this briefly, that when this is not in place, it can make the work of clinical personnel at the hospice very difficult. And when it's actually in place, but also the care responsibility for the carer can bring about very emotional turmoil, very, very difficult it can be very difficult for the carer to make a decision about end of life when advanced care planning is not in place, because they have to make decisions, very important decisions, based on what they think the person may want. So can have, well, negative consequences for their mental well-being. Barriers to access, I briefly explained. What happens is that with people with dementia, they're more likely to end up in an emergency hospital, and then perhaps either in geriatric inpatient care in the ward, or sometimes they are discharged to either hospice or back to the home. So the second theme, and these are all these sub-themes, there was the first sub-theme working at the hospice. This was quite interesting. So the clinicians reported, described very well what their type of work was like within the setting, within the hospice. So we felt that sharing this knowledge could be helpful, because that there is other care providers can understand what the type of work they're doing for dementia, for people with dementia. So the type of dementia support in end of life and palliative care. So this is the Sunflower Center. Most all staff members refer to the Sunflower Center as the type of support that outpatient care, so people doing outpatient care, can access, and with their family members. It's a quite nice way to engage an activity for cognitive stimulation, but also just for the good of spending time with their family members, and also with other people with dementia attending the service. And also the information sharing within hospice care. So there are nurses, admiral nurses there that can share. This is a quite good feature, I believe, that they can share within the hospice. They can share the knowledge of dementia, so they can basically be there for whatever need the hospice staff may have about providing care for people with dementia. So it's very, I think, could be quite effective. And being a carer in the end of life dementia care, this is another sub theme, and they reported being excellent in understanding their loved ones with dementia needs and preferences. But this can be quite stressful anyway, because they need to basically talk on behalf of someone else. Care expectations. Carers reported that the hospice asked them about care expectations, the type of expectations they had about end of life care. I believe only one carer reported not being asked this type of the type of expectation they could have. But when this was the case, there was probably more confusion about what the hospice can provide to people with dementia. So it always, of course, advisable to share this information. But the other good thing that I found through discussion with participants was that the clinicians tended to double check with the carer their care expectations during the care. So not just at the time of accessing access, but also throughout the care, because they may change the expectations they initially had. Also, there may be some assumptions they may have about the person being discharged, or dementia not being as progressive as they thought it could be, in case some of the symptoms may vanish. Okay, so discharge pathway. I think I shared this, and this was quite distressing situation for carers, for all of them, because I think that if there is this was shared about by clinicians about the existence of discharge for people with dementia, but I think this I don't know whether this happens across the UK, but I think that is quite important to actually to say what this charge is for people with dementia. And this is not because the person with dementia does not need end-of-life care anymore, but this is just because they are staying there for longer than expected. And so they may need other type of care. Okay, so the key, I was curious about key features of this Cheshire model of care, and the clinicians reported that they think that what they provide so well for people with dementia is the holistic type of care they provide. They don't limit necessarily to the clinical input for what they have been trained for. But they try to look beyond that. And so they was saying before, they would probably have a cup of tea with the carer during a break and talk to them, and also to try to soothe the agitation of the patient in other ways, not just through medications. And they reported that their type of care is compassionate and comfort. They provide comfort to the patient. Bereavement support. This is quite crucial theme. So they pretty much all the carers I talked to, they were very, very. I think they were very emotional. So the questions I asked, I tried to be very, very tactful in the way I asked them, but it was about death or their experience of end of life. So it was quite difficult for them. And not all of them knew about the existence of bereavement support that is provided within the hospice. So a good feature of the of this hospice is that they provide after the person has passed away. So that after the death of the person, they contact back the carer, and they try to see whether they explore whether the carer needs support or not. So this is a quite good thing to do. I don't know whether this happens in other settings as well, but I'm sure that if the person, if the carer does not access end-of-life care, they may be very much on their own, looking elsewhere in the community for bereavement support. So, okay, so this is the care pathway, and I try to simplify in a diagram. It can be quite difficult or daunting to read, but as a quick look. But what they, at the very beginning, you can see that there is dementia during advanced stages. And then the person with dementia, because of their living with frailty, they're more likely to experience, for example, fall-related injuries or other injuries that may that may make them very likely to go to be admitted to hospital emergency care, and or either access to hospice care or hospital emergency care. Sometimes through hospital emergency care, there is hospital discharge that is back to hospice care, or that is to hospice care. But sometimes then the longer staying in the hospital would lead them to inpatient hospital care in geriatric ward, or they are sometimes back home. And you can see that when they are back home on the right side up, when they are back home, the bereavement support is very much on the carer. So it's a question mark. What happens for the carer then? There is in the community support, but it's not necessarily well shared, this type of information with them. So when they access the care, they have the support of the Sunflower Care Center, so they can discuss about advanced care planning. And they can choose between inpatient hospice care or hospice at home rapid response type of care. So one is inpatient care. They provide 24-hour care. And this is advisable, as talking to clinicians, it seems more advisable to very complex cases. And whereas the hospice at home rapid response team would visit routinely the patient at their home, And of course, there is very little disruption in the care environment, but there is no 24-hour care support, specialist support. So in that case, the care needs to be coordinated with district community nursing teams and primary care providers. There are also Macmillan nursing teams and matrons as well. But some of the care, well, to be honest, out of our support, even if the hospice clinicians can visit them, but during the night, the twilight hours, well, basically during the night, it may be very much on the shoulder of the carer. So there is increased responsibility. And even if the carer can still count on clinical support from the hospice or from the community, but the idea of having the person at home can still be quite daunting for them, because they may feel they are still the main care provider. Okay, so so bereavement support, that's a good thing. So in either case, either inpatient hospice care or a rapid response team at the home of the person, when the person dies, then the carer can still access support, bereavement support, through the hospice. So this is a quite good feature. Okay, sorry. So this is what we found and key implications for policy and research. I wanted to engage with questions as well. So I don't know whether should I pick some of the questions now, and then we can talk about some of the things I found and key implications. Because I see 6 in the chat already.
It's up to you, Alessandro. We've got 15 minutes left. So whether you know,
we have time for questions if I go.
So we're at 2:45 now.
Okay, no, probably I go with the questions, because basically this is just a summary of what we found. So one thing that I wanted to say, that the systematic review has been submitted to journal. So things may change after we receive the reviews back from the journal editors. And also for the qualitative studies, the study findings I've shared now, I do not expect them to change massively, but as it happens, after you submit to a journal, then they will get back to you with comments. So some of these may need to change. Okay, so.
Yeah. Thank you, Alex. It's really good. It's very important research, certainly. Can you have a quick question, then open to the floor? Okay. From your research, have you identified what's the key difficulties for the dementia patient care? What's the challenge they have?
You mean as a researcher? Sorry, Ari.
Yeah, I mean, you did the research look into the care of the dementia patients, and the stress on the care is very, very strong. And have you identified what's the key challenge for them? Why they are getting so stressful? What are their needs?
Yeah, so yes, definitely. So I think the unpredictability of dementia and the uncertainty of disease trajectory, that's the two things that came across as very, very challenging for them. So because dementia is difficult to understand when it's the time for them to access end-of-life care. And there is still some confusion about dementia being a progressive condition. And so also because there are symptoms linked to dementia. So people may become very agitated, for example, but this agitation may fade away with right clinical input. So the remission of some of the symptoms may be seen as dementia being more stabilized in some carers. So I think there is needs to be very clear about what dementia is and what type of end of life care what is needed for this patient group. Yeah.
Thank you very much. Thank you. There is any questions from the audience? Please, you can raise your hand and open your switch on your microphone. You can start to ask, or there is a number of questions in the chat. Alex, can you see? Maybe you can answer one by one.
Okay, so the question is, from Richard, do you think that palliative care is effective with the lack of the patient vocalization of their needs, and the fact that dementia can need long-time care, and therefore time needing the care means they don't want to get involved too soon? Yeah, that's quite a good question. And yes, so it's inevitable for them to lose, as you are saying, the ability to engage in verbal communication. And so even if there is no palliative care there, they still would lose their ability to engage, to verbally share to make their voice heard. So I think that's the good thing. It's very tricky, also because, as you are saying, that dementia can need long-time care. When is the time for them? And also, people may not want to get to the hospice when it's too early for them. They still want to be in the care environment. And one thing that I in response to that, by talking with clinicians, I think there is the need to increase awareness about the Hospice at Home Rapid Response Team. This is the way it's called in East Cheshire. It may be called in different ways, but basically it's a Hospice at Home service. Because in that, yes.
I mean, that seems fine. Yeah, I mean, that seems very good. But I know from personal sort of experience that they don't even want to get involved with that. You know, there's a phone line, but the thing is, you're sort of turned to, you know, everybody just seems to sort of leave you at this plateau, if you know what I mean. Yeah, there's a plateau going on that, well, you're not getting any worse, and it just seems to be. I mean, that seems like a wonderful system they've got in Cheshire, but you know, it's not, you know, there's Rolls-Royce service somewhere and, you know, sort of Model T service somewhere else. We need to nationalize a standard. And then, you know, it's, you know, I don't know, it just seems a problem that there seems to be a turn off. If you had cancer, you know, they know you've got 3 weeks to live, or 3 months or whatever, they can come. If you've got dementia, it could be 8 years. And so there's this feeling from the medical profession generally, you know, that when do we get involved, and when do carers know that they've got to sort of push the red button, as it were. There's, you know, there's not I don't know what the answer is, but there doesn't seem to be that link up between carers and the medical system, if you like. Yeah.
Yes, and Richard, may I add something as well? So before I joined this project, I had assumptions myself about the hospice, because not this hospice, but in general, the hospice setting, because in the past I had an assumptions of hospice as a very sad place where really people go there to die within days or weeks. And even though this is the short-term nature of the hospice is still true. I mean, you don't go there for a long stay, but they are not set place to stay. And there are people who may actually benefit from outpatient care, for example. So you don't necessarily need to access inpatient care if you don't feel like leaving your care environment. But it may be time for people if the care environment, I believe, becomes too challenging for the carer, and the patients are not receiving good quality care. I think it may be time for them to access this type of care. And I believe, and I agree, there is a mismatch between what is being offered and what actually people are wanting to access. So because we need a nationwide acknowledgement of these type of services, and maybe we need to also encourage discussion about how the service can reach better the patient, and maybe in different ways as well. It may be that home-based support, it may be good, but in different ways, not necessarily how it is now structured. But I think we need some discussion going on. Okay, so Donna.
Thank you. Sorry.
Yeah, thank you, Richard. Thank you, Donna. We will get a copy of yes. I think Emily, can we
Yeah,
share?
that's fine, Donna. If you want to just send an email to micra@manchester.ac.uk, I can send you a copy.
The only thing I should say, sorry, is that because I'm a bit restricted with the fact that the journal requires no sharing of publication material. So I may be able to share the slides, and I will, but if I can share them at a point when I submitted the empirical study to the journal, so that I can let the editor know that some of the material has been shared with the public, if you don't mind, Donna. And
okay, thanks. Cheers.
Okay, thank you.
Thank you.
Okay, and then Ben, really interesting point. The carers always welcome the carer transition on admission to hospice, so did it also cause them against an issues? Yes. Well, they were very much well, they were very much puzzled about releasing their care responsibility, their caring role. But there was a point when they reported, this was commonly reported, Ben, that they felt that there was a point when being a carer was worse than losing their role. And because the caring responsibility was so daunting for them, and also they reported that there were times of the day they could not effectively support as they wish the person. So there was a point that they noticed that there wasn't much they could do because more specialty support was needed. But I would say that the end of life care is not easy at all for carers. Not for none of the carer I've been talking to reported positive experience of being a carer during end of life care. So yeah, so that was very, very difficult. So I think if there is support for them as well, not just bereavement support. So the hospice spend time with the carer, but I think some type of support may also be done within the community so that they don't feel isolated when they leave the hospice, when they visit the patient, and when they leave the hospice, they don't feel home on their own with their thoughts and emotions, but they still need, they know that there is someone they can talk to within the community. But yeah, but that's probably would need a different study. So
We've just got 2 minutes left, Alessandro.
Yeah, so I'm running. I'm an admirer in the community. A lot of patients have become.
I think the next question there is about the technology.
Okay,
so during the interviews or generally at the hospice, was the use of digital health technologies like mobiles, apps, websites, electronic diaries used? If so, did they pose any challenges in dementia care?
Yeah, sorry, Emily, I lost you.
Sorry. What kind of technology did they use at East Cheshire? So did they use any apps or websites, electronic diaries? And did that use pose any challenges in dementia care?
Oh, okay, that's a good question. So I didn't look specifically to technology in the hospice, and this is actually quite nice topic to look at in a different study. And so there is a website, it's very rich with information that East Cheshire has, but I'm not entirely sure. So I will probably need a clinician from the hospice to talk about this type of feature. But yes, that's quite good to know, to be honest. So where is oh yes, that was the question.
Lovely. I think then we've just got some sort of comments rather than questions. So
Okay.
Debbie's just said that we try to support the person with dementia and their carers as early as possible in illness, usually through daycare support, but this might not be the same across the UK. Yeah, lovely. I think we are at time. So I think if we don't have anything else, just a really big thank you, Alessandro, for presenting.
Thank you. Oh, thank you, Debbie, for answering the question. Thank you. I just noticed. Okay, thank you very much. Thank you, everyone. Thank you, Emily, and Harry for sharing.
Thank you. That's very nice talk. Thank you.
Thank you, everyone.
Yes, great.
Thank you,
Thank you.
everybody.